We have another great month of article reviews. I'm Dr. Neil Skolnik, professor of family and community medicine at the Sidney Kimmel Medical College of Thomas Jefferson University. And joining me, as always, is my co-host.
I'm John Russell. I'm a clinical professor of family and community medicine, also at Sidney Kimmel Medical College at Thomas Jefferson University. Neil, it's great to be with you tonight.
And John, this is another set of great articles. We're going to start with a fascinating article using AI in real-world prospective validation and economic evaluation of deep learning-based diabetic retinopathy detection from fundus photographs. And this is a systematic review and meta-analysis of kind of this new world area published in Diabetes Care. Then an article on orforglipron, an oral small molecule GLP-1 receptor agonist for the treatment of obesity in people with type 2 diabetes, the ATTAIN-2 trial. This was a phase 3 double-blind trial published in The Lancet. Then we're going to discuss the removal by the FDA of suicidal ideations for GLP-1s. Then an article titled Effectiveness and Safety of Statins in Type 2 Diabetes According to Baseline Cardiovascular Risk. And this was a target trial emulation study in the Annals of Internal Medicine. And our final article this month is GLP-1 receptor agonists and the risk of optic nerve or vision-threatening events in patients with type 2 diabetes or cardiometabolic disease, a meta-analysis of the randomized controlled trials published in Diabetes Care. John, we're going to start with that study on AI, real-world prospective validation and economic evaluation of deep learning. Deep learning was something I used to think you and I did, but now it refers to AI. Of deep learning-based diabetic retinopathy detection from fundus photographs, a systematic review and meta-analysis. I know this is something we've touched on before. Deep learning has shown a lot of promise for detecting diabetic retinopathy using fundus photographs. And this article sought to assess the feasibility of implementing deep learning for diabetic retinopathy systems using fundus photographs across different countries, different systems of care by synthesizing prospective validation and economic evidence. They searched 5 databases. Studies were prospectively assessed using or looking at diagnostic performance, and they looked at economic analysis. They looked in total at 47 studies. This is a lot of information included in this meta-analysis, and the pooled performance was highest in detecting vision-threatening diabetic retinopathy. The area under the receiver operating curve was 0.974, just to put that in perspective. Above 0.8 is considered good, above 0.9 is considered really good, meaning has very good sensitivity and specificity. The next best at detecting was any diabetic retinopathy, where the area under the curve was also, frankly, fantastic, 0.959. 15 studies were included in the economic commentary, showing that this was cost-effective in high-income countries, and in middle-income countries, the results were mixed. John?
So, Neil, this is something that you and I have been doing in our practice for a while. You know, I think there's a lot of things that you don't get if the only evaluation of someone's retina is just a photograph taken in the primary care office. And they don't always work. So sometimes we'll get kind of notices back that things are inconclusive. But certainly this is infinitely better for our patients who do not find their way to the eye doctors. And there is kind of more and more people who, for lots of reasons, just are not meeting the guidelines that we recommend to them to get to the eye doctor. So, you know, interestingly enough, that this is something that makes most sense in a more resourced country versus a less resourced country. And one would think in a less resourced country that this might this might make more sense. But so I think it is something that does kind of get more people in that area under the curve for being evaluated. I think as we are using AI for kind of more and more things, that we are going to see some of the static things that are looking at images, be it a fundus photo, looking at a pathology slide, looking at an X-ray. I don't think things will solely be done by AI. Certainly you need some quality assurance being done with some, backup reads and double reads. But, for our colleagues who are ophthalmologists, there's probably more good they can be doing seeing patients live or being in the operating room than necessarily just looking at photos from our office. And so I think that this is an exciting thing. And I think we are going to see more of this happening, especially for things that are static. So our next article is from The Lancet, and it looked at orforglipron, and a oral small molecule GLP-1 receptor agonist for the treatment of obesity in patients with type 2 diabetes. This was a phase 3 double-blind, randomized, multi-center, placebo-controlled trial. So this was a 72-week phase 3 double-blind, placebo-controlled trial that was conducted across 136 sites in 10 different countries. Participants had a BMI of 27 or greater, an A1C of 7 to 10, and they were randomly assigned 1 to 1 to 1 to 2 to oral daily orforglipron at 6 milligrams, 12 milligrams, 36 milligrams, or placebo. The primary endpoint was the mean percent change in body weight from baseline to week 72. Their treatment regimen estimated randomly assigned participants, regardless of intercurrent events, was the primary estimate, and with the efficacy estimate considered supportive, safety was assessed in all patients who were treated with at least one dose of study drug. So the study went from June of 23 to February of 24. There were over 2,800 participants screened. 1,600 of the patients were female, which would have been about 46%. They were randomly assigned following a dose escalation phase to receive either 6 milligrams of the orforglipron, 12 milligrams, 36 milligrams, or placebo as an adjunct to lifestyle modification. 1,444 patients completed the study. The baseline body weight was 101 kilograms with a BMI of 35 and an A1C of 8. For the treatment regimen at period, the mean percentage change in the body weight from week 72 was a decrease in 5.1% with 6 milligrams, the estimated treatment difference being a decrease in 2.7, a decrease in 7.0% with 12 milligrams, an estimated treatment difference of a decrease in 4.5, and 9.6% with the 36 milligram dose of orforglipron versus overall a 2.5% decrease with placebo. All prescribed weight and cardiometabolic measures, including A1C, statistically significantly improved with the orforglipron. Treatment discontinuation due to adverse events, mostly GI related, were higher for orforglipron. So at the 6, there was a 6.1 to 9% decrease versus placebo 4.1%. The most common adverse events with the orforglipron were mild to moderate GI events that would predominantly happen during dose escalation. 10 deaths were reported during the study, 6 in the treatment group and 4 with placebo. Investigators deemed all deaths unrelated to the study, except for 1 case in the placebo group and 1 in the 12 milligram orforglipron group. For the case in the orforglipron group, no treatment-related association was reported. Neil?
John, I think this is a fantastically exciting medication. So the trial that you just went over, ATTAIN-2, was the complementary trial to ATTAIN-1. Remember that all medicines that are going to be submitted to the FDA for review for treatment of obesity have to have a trial in people with obesity without diabetes, and a separate trial in people with obesity with diabetes, because in general, you lose about a third less weight in all of the trials in the people who are in the trials of people with obesity and diabetes. So attain one, which was orforglipron in people with overweight and obesity without diabetes, showed a weight loss of approximately 11%. And it had the same or similar decreases, improvements in metabolic parameters that all the GLP-1s did. There were improvements in waist circumference, systolic blood pressure, triglycerides, non-HDL cholesterol levels, all improved, as we would expect. The other thing in the ATTAIN-2 trial, which you just said that's worth noting, is that the decrease in A1C was quite impressive, a decrease of 1.66%, which is in the same range as in the ACHIEVE-1 trial, which was orforglipron in people with early diabetes. In that trial, also in the New England Journal last year, mean A1C was 8%, mean decrease in A1C was approximately 1.5% in the people on orforglipron. What does this mean? Well, it means we have a new oral medicine that is currently at the FDA right now, as we speak, under expedited review, that has particular exciting characteristics. It is a small molecule, non-peptide GLP-1. Why is that important? Well, it's important because its absorption orally is in the rate of 70 to 80%. That's fantastic. Very different than, for instance, oral semaglutide, where the absorption is only about 2 to 3%. Oral semaglutide, remember, just came a couple of months ago to the United States, FDA approved, and now has come to market. Also a fantastic oral option for GLP-1s. Orforglipron is different, though. Absorption is good, and therefore it's easy to use. There are no problems taking it with food or with water. It doesn't have to be taken at a particular time of day. What is also meaningful for this compound worldwide, and this is particularly as opposed to the injectable forms of GLP-1s, injectables are very subject to temperature variation. At every point along the supply chain, they have to be kept at a cold temperature, and that is not easy to do in many areas of the world. A small molecule non-peptide doesn't have any of those requirements, which makes distribution, which you and I don't think about a lot, but it's important if we think about how important of a problem obesity is worldwide and the need for therapy worldwide. So it's going to be easier for distribution worldwide. It's easier for patients to take on vacation with them. And for people who prefer not to have an injection, this will, if it gets FDA approved, as these trials suggest it likely will be an excellent option for people with obesity and for people with diabetes and obesity. The next piece of information we're going to discuss is an announcement by the FDA on January 13th that they have requested removal of suicidal behavior and ideation warning from GLP-1 agonists for obesity. Remember, this was a warning across all medications for obesity when the GLP-1s were first approved, and this has not been a warning on the GLP-1s for diabetes. Basically, this was announced because a very complete FDA evaluation that we'll talk about in a moment did not identify an increased risk of suicidal ideation or behavior with the use of GLP-1 medications. And so that they've requested removal of that from the product label. As I said, at the time of original approval, that was just labeling across all oral obesity lowering medications. So what did the FDA do to come to this conclusion? Well, they initially reviewed GLP-1 clinical trials and found that there wasn't an association between the use of GLP-1s for obesity and the occurrence of suicidal ideation. But there were a relatively small number of cases of suicidal ideation observed in the individual trials, and that meant there was considerable uncertainty in the risk estimate. So, to address that concern, the FDA performed a comprehensive meta analysis of all clinical trials across GLP 1s to improve the precision of the risk estimate. There were 91 placebo controlled GLP 1 medication trials in the meta analysis, over 100,000 patients. And that meta analysis, again, did not show any increased risk of suicidal ideation. And in addition, the FDA conducted a retrospective cohort trial using a large administrative claims database comparing GLP 1s to SGLT2s in people with type 2 diabetes. That study population, John, was over 2 million people. And I just want to say, when I look at how carefully FDA approved medications are examined, and then I think of how people tout non-FDA approved compounds and things so lightly off of, on TV or in magazines or social media. I think our heads should be examined to even think about those non-FDA approved things. So the FDA then looked at a study population over 2 million users and again found no increased risk of intentional self-harm on GLP-1s compared to SGLT2s. They did not find any increased risk in any subgroup, either with diabetes alone or obesity. They then also reviewed published observational and pooled studies, same conclusions. Therefore, after that comprehensive review, the recommendation to withdraw this warning. John, your thoughts?
So, Neil, I think for our listeners, that this being withdrawn is not going to change what they do, but it's a kind of an interesting concept in that, a medicine comes out, and if you think about some of the medicines during our career, varenicline, which is the most effective medicine for treatment of tobacco addiction and helping people get off tobacco, carried this stigma for a while until the FDA actually pulled this. Doxycycline. Wow. If you think about, Accutane, isotretinoin kind of carries some of these things with it. So if you look, there was a nice review article kind of last year in one of the Lancet journals that actually looked to see, what categories of medicines actually truly kind of carry this over kind of a long period of time. The number one medicine is going to be alprazolam. Number two is zolpidem. It's going to be some of the medicines that are for anxiety or sleepers are category one. Number two is antidepressants, and there's a wide variety of antidepressants in there. And the third kind of major category is anticonvulsants. So for the context of diabetes, we might have some people who are on something like a gabapentin or a pregabalin or something for some neuropathy. But, I think, proving causation is really kind of difficult, and people's lives are not necessarily linear. There was a rock and roll star from the early 1960s named Del Shannon. In 1961, he had the number one song in the country called Runaway. In the 80s, in the early days of fluoxetine coming out, he was started on fluoxetine for a very severe depression. And several weeks into the course of his therapy, he committed suicide and led to a large lawsuit that was eventually dismissed from his family to the makers of fluoxetine. So, it becomes very easy to kind of take a medicine, and you'd probably rather live in a world where someone's going to say, hey, there's been some reports of this. Let's look at 2 million. Let's look at 2 million people who've gotten this to see if the signal is, any louder. And I think, with med safety, it's in constant evolution. And I think sometimes when we are hearing some kind of criticisms of medicine and drugs and things like that, it's, well, how come they didn't know? Well, if something happens, 1 in 10,000 patients, you're not going to see it in a study that had 3,000 people in the treatment arm. So I think having post-marketing information is what allows us to be as safe as we can. This is something we need to be kind of mindful of, but we should be able to prescribe our GLP-1 medicines without worry about suicidal ideation. Our next article is from the Annals of Internal Medicine, looked at the effectiveness and safety of statins in patients with type 2 diabetes according to baseline cardiovascular risk. So this was a study that looked at participants between 25 and 84 years of age in the United Kingdom with a diagnosis of type 2 diabetes between the years of 2005 and 2016. The patients had no history of CAD, myocardial infarction, stroke, heart failure, myopathy, liver disease, rheumatic heart disease, schizophrenia, or cancer. Patients were started on a statin versus non-initiation, and they estimated the observational analogs of intention to treat effect. Statin initiators were propensity score matched to non-initiators in a 1-to-4 ratio with a Q risk 3 strata of 10-year predicted cardiovascular risk. Patients were stratified as having a low risk of under 10%, intermediate 10 to 19%, high 20 to 29%, and very high greater than 30%. They measured the absolute risk differences in risk ratios at 10 years of follow-up for all-cause mortality and major cardiovascular death, as well as myopathy and liver dysfunction. What they found was statin initiation was associated with reduction in all-cause mortality and major cardiovascular disease across all of the strata of risk, the 4 different categories. In the low-risk category, the risk difference as well as the risk ratio was a decrease in 0.53, and the risk ratio was 20% lower for all-cause mortality, and decrease of 0.83 and 0.78 respectively for major cardiovascular death. A small increase for myopathy was observed in the moderate risk stratum only, and there was no associated increased risk for liver dysfunction in any of the categories. Neil?
John, I'm going to approach my thoughts on this article in 2 different ways. One is a brief comment on what the article concluded and putting it in context of the ADA's current recommendations and data that's out there. But then I want to talk for a couple of minutes about target trial emulation studies in general, which is something we're seeing a lot more of lately. So just realize the risk difference is the absolute risk reduction. Risk ratio we're used to seeing is the relative risk reduction. A risk difference of 0.5% here means that 1 person out of 200 over 10 years benefited. Now, the benefit was important. It was decreased mortality. And it's always important to look at that rather than just say there's a 20% decrease. So the authors really conveyed that nicely and clearly. This is, it's not a surprise, right, to see that statins work in people with type 2 diabetes. The ADA recommends moderate intensity statin therapy for primary prevention in adults with type 2 diabetes who are over 40 years of age. They recommend high intensity therapy be considered in those with additional risk factors. And this is based on a lot of trials out there. There was a meta-analysis of over 17,000 people with type 2 diabetes that showed a approximately 20% reduction in major vascular events for every 40 milligrams per deciliter reduction in LDL cholesterol, which is about what you get with a moderate intensity statin therapy in people with the usual elevated levels of LDL. There have been primary prevention trials, but none of those trials looked at people with very low cardiovascular risk, which is what this trial attempted to do. And the reason no randomized trial looks at that is that the trial would have to last a very, very long time to show a benefit, or have to examine a very large number of people. And that's where observational trials. Oops, I said observational trial, John, and they called this a target trial emulation study. Was that a mistake the way that I said it? Well, it wasn't. I said I discussed target trial emulation studies. For years, observational trials, cohort studies have been what we've used to look at things that are not examined in prospective randomized trials. Our data sets have become more accessible, they've become much larger, and that's led to the emergence of real world evidence as an important form of evidence that we use. A target trial emulation study is a type of observational trial that defines ahead of time the inclusion criteria for who's going to be included in the observational trial, how long they're going to be looked at, what parameters are going to be looked at. So it tries to mimic or emulate a randomized trial. But don't let that fancy name fool you. It's still an observational trial, and its main Achilles heel remains the potential for confounding variables to affect the outcome. And when it comes to thinking, are there likely confounding variables, it comes back to all of us using our critical analytic skills to say, what might that be? I think in this trial, frankly, it's easy to think of a confounding variable that invalidates the result. And that confounding variable is that people who are on statins, who are on low risk, might be either taken care of by doctors that are more aggressive in taking care of every risk factor they have, or might be people who are just more attentive to their own health. And it wouldn't be a surprise that over 10 years, they have better outcomes. So I don't disagree with the conclusion that statins are likely beneficial for people at less than the usual 7.5% ASCVD risk score, 10-year risk. But I think we should be careful not to confuse target trial emulation studies, which is just another name for observational trials that might have confounding variables, with real prospective studies. For our final article of this month's issue, we're going to look at an article from Diabetes Care titled GLP-1 Receptor Agonists and Risk of Optic Nerve or Vision Threatening Events in Patients with Type 2 Diabetes or Cardiometabolic Diseases. This was a meta-analysis of randomized controlled trials. There's been some conflicting information out there around GLP-1 receptor agonists and on the risk of ischemic optic neuropathy. So the authors attempted to synthesize current evidence of GLP-1 receptor agonists on the risk of optic nerve or vision threatening events from randomized controlled trials in patients with type 2 diabetes or cardiometabolic diseases. They looked at a total of over 83,000 participants from 20 published randomized trials. The primary outcome was a composite of optic nerve or vision-threatening serious adverse events, including ischemic optic neuritis, ocular ischemic syndrome, papilledema, blindness, blurred vision, visual impairment, and reduced visual acuity. Over a mean follow-up duration of approximately 3 years, GLP-1 receptor agonist use was not associated with increased risk of primary endpoints. There was an odds ratio of 1.2, but it did not reach statistical significance. Pre-specified individual adverse events, including ischemic optic neuritis, which had an odds ratio of 1.5, but a confidence interval that ranged from 0.49 to 4.6, and vision loss and disturbance events, an odds ratio near 1, were not significantly associated with GLP-1 use. John?
So, Neil, kind of an interesting thing, and I think this kind of ties into what I talked about earlier about some of the risk with regard to suicidal ideation related to a drug. again, I don't think that this is something that is hitting a lot of the literature that you and I are bumping into month over month. But in kind of prep for talking about this article, I took a dive into some of the vision literature. And certainly, this is something that there are papers by the American Academy of Optometry and the American Academy of Ophthalmology. And there are kind of signals that are being kind of raised in some of these professional organizations about some of these medications. And I think that this is also a great example of some of the checks and balances, right? So if you look at that ischemic neuropathy that can happen, it happens, pretty rarely, about 1 in every 10,000 patients. So not something that someone's going to see very often in kind of a smaller study. But I think this meta-analysis is really reassuring. And I think ultimately, without kind of going through every different eye condition, at the end of the day, they could say with these 83,000 patients that they found that no one was at increased risk of anything that lost their vision. And in fact, overall, kind of depending on where we are in the course of someone's diabetes, better glycemic control, which is going to be attached to all the GLP-1s, is going to lead long-term to better retinal health, better microvascular disease control. You might not see it kind of later after someone has already developed that. And even they kind of tease that out, that it really didn't make a difference if someone entered into one of these studies with pre-existing retinopathy or not. So I think that this should be reassuring that the signal that we're hearing, at least at this point, is really not associated with it. But they cannot completely rule out things that happen in a very low incidence. So again, if this meta-analysis had 80,000 people in it and there's something that happens 1 in 100,000 people, the study was not put together enough to pick up kind of all of those events that are more rare than the N that was in the study.
John, before we conclude, I just want to remind all of our listeners to listen to a new journal podcast that is now on our feed, and that podcast is of the new American Diabetes Association's journal, Diabetes, Obesity, and Cardiometabolic CARE. Really some fantastic information. And this month, that podcast is going over the new ADA's Obesity Association's Standards of Care for Overweight and Obesity. Really fantastic podcast. Take a listen. For more information and links to the articles that we discussed in this issue, just go to diabetesjournal.org. Until next month, keep listening
and keep learning.